Welcome to week 10 for hematology. So this is our last PowerPoint that we have to go through for the quarter. So just one PowerPoint this week, which I'm sure is a relief to most of us. So we're just going to get ahead and get started. I need to just find it here. There we go. All right, so I believe it's chapter 26, but it's the chapter that focuses on hemolysis or extracorpuscular defects leading to increased red cell destruction, immune causes. So in other words, this PowerPoint is full of more topics on hemolysis, but this is all related back to antibodies. So that's where the immune word comes in. Anytime you see that word immune, you should be thinking that an antibody is involved. So that will be the focus. An antibody will be helping cause the hemolysis that is occurring. All right, so just kind of skip through the objectives for now. I'm just going to preface this with saying there's not going to be a lot for you to remember out of this one. It's going to be pretty brief, which is probably okay because I think our hands are full with the amount of information we need from weeks 1 through 9. But at any rate, again, an immune hemolytic anemia is any sort of hemolytic anemia in which you will have antibodies, whether they be auto or allo, that bind to the red cells and then destroy those red cells. The antibody itself doesn't necessarily destroy the red cell, but when they bind to it and then they travel through like the spleen, the macrophage identifies it as abnormal with the antibody on there, and then the macrophage will phagocytize and destroy the cell itself. So that's how it results in a hemolytic process. Now, for those of you that haven't been through immunology or might not be familiar with the terms auto and allo antibodies, I just want to quick define them. You'll hear about them in immunology and especially in blood bank. But an autoantibody is an antibody that your own self has made. So it's an antibody that your self made that's attacking yourself. This is the kind of the cause behind like arthritis, like rheumatoid arthritis, lupus. So there's a bunch of what we call autoimmune diseases where people all of a sudden start making antibodies that attack themselves. So that would be an autoantibody. In medical terminology world, auto always means self. Alloantibody is you get it from somebody else. So maybe you got a blood transfusion, and in that blood transfusion, you picked up an antibody from another person, whoever's blood that was. It could be that you shared a drug, like needles, things like that. So somehow you picked up an antibody from somebody else. That would be an allo. At any rate, as you can see, the premise of this whole thing is that when the antibody attaches to that red cell and they travel through the spleen, the macrophages remove them and hemolyze those cells, and that's the hemolytic part. So in the lab findings, as always, hemolytic anemias are normocytic, normochromic anemias. So depending on if it's an intravascular or an extravascular, you're going to see spherocytes or schistocytes. In both, you're going to see reticulocytosis, so that increased retic production because the bone marrow is going to really be kicking out a lot of retics to replace the destroyed red cells. So here are the ones that we have classified as immune hemolytic anemias. You have the warm-reacting autoimmune, cold agglutinin disease, drug-induced, and alloimmune. So we'll just touch on a couple of these. So starting with that warm-acting autoimmune hemolytic anemia, again, autoantibodies are attached to the red cell surface. Typically, it's secondary to something else happening in the body, some sort of autoimmune process in general. That's why you're making autoantibodies. So to diagnose it, we would want to see that there is an autoantibody present to be causing this. So there is a test that's called DAT, direct antiglobulin test. Now this is a blood bank test. We perform this test in the blood bank. So when you guys get into blood bank class, you'll learn a lot about it. I'm not going to focus on knowing it here because you learn more of it there. But essentially what the DAT is going to help tell us is if there's an antibody attached to the surface of that red cell. If there is, in this test, they will agglutinate together and show up as a positive, and that positive DAT result tells us, yes, there are antibodies attached to the red cell surface causing hemolysis. So that's it. You don't have to know anything else about it. You'll learn it all in blood bank, and then that's the class where you'll have to really know it. All right, so when we talk about warm reactive autoimmune hemolytic anemia, we are discussing specifically IgG types of antibodies. So if you've been through immunology, you should be familiar with the different types of antibodies. Those that are IgG tend to react at body temperatures, which are the warm temperature. That's why we call them warm reactive. They like that 37-degree kind of temperature. So that is, and of course our bodies are that temp, so they will react within us. So please do know that the warm reactive autoimmune hemolytic anemia is IgG-based antibody versus the cold reactive. The cold reactive are typically the IgM type. So as the name implies, they like a colder temperature. Oftentimes it's room temp or below. So anywhere room temp and below, they like to react. So they're not going to react inside the body, but when you go to draw their blood, and I don't know if any of you who've worked in the field as phlebotomists or known somebody, but in seen a cold agglutinin, this is what happens. So a cold agglutinin disease is another name for a cold reacting autoimmune hemolytic anemia, in which inside the patient at a 37-degree body temp, everything's fine, everything's moving along, nothing's getting triggered to react. Once you go to draw their blood inside that tube, you're going to notice that all of a sudden it clumps together, the blood inside the tube clumps. Even when it's not supposed to, and say like an EDTA tube where it's supposed to stay liquid, it clumps together. And that's because these IgM autoantibodies, when they hit the colder temp of the room, they react. They're triggered to react, and now they clump the blood together. So that would be cold agglutinin disease. It is something you're definitely going to see at some point in your career if you haven't already seen it. What we do to fix it is warm it back up. So people that we know that come through that are known cold agglutinins, we basically know that we have to always put their samples into a warmer, make sure it warms back up. It gets rid of that IgM. As soon as you warm up their blood back to that 37 degree, the agglutination disappears and their blood is liquid again. And that's key. We can't run clumped blood through the hematology analyzer, so we need to make sure we warm it back up before we run it so that we can have a good sample. So that's kind of the trick with cold agglutinin, is warm it back up to get it back to that 37 degree, and the cold agglutinin antibodies go away. There is a disease called paroxysmal cold hemoglobinuria. This one's kind of a tricky bugger. The name is cold, so it tells you it's a cold-generated hemolysis, just like we just talked. But it's actually an IgG-based antibody. Now, I said here on that previous slide that typically cold-reacting are IgM, and that is usually always the case, that IgGs are warm reactors and IgMs are cold reactors. Well, this one is unique in that it is an IgG antibody, but it's in what we call a biphasic antibody, meaning it will start and kind of bind with complement in colder temperatures, even though it's still an IgG. It won't lyse completely until after you warm it back up to that warmer temp that IgG is used to reacting with, but it can start to bind in the cold, and then it will do the full lysis after warming. So this is kind of the exception to the rule, if you will. So PCH, paroxysmal cold hemoglobinuria, is an IgG-based hemolytic process. So it's still an intravascular process, so you're still going to see the same signs of hemoglobinemia, hemoglobinuria, you know, reticulocytes, and that kind of thing. All right, so here is your chart. If anything out of this PowerPoint you know, it should be this chart. So it kind of gives you the main three here that we just went through. So again, warm reactive, primary antibody involved is IgG, likes to react at 37 degrees. Hemolysis is typically extravascular, so that would be more the spherocytes seen with that. Cold reactive is IgM based. Again, it likes 15-degree room temp and below. It definitely involves complement, and then it can be either intra or extravascular. And then paroxysmal cold is that biphasic IgG, but it's still kind of a cold reacting temperature that it starts with. Definitely involves complement, and then it's intravascular. So in one of the rows toward the bottom, it talks about autoantibodies that might be involved. Cold reacting typically involves an autoantibody that's called I, and then paroxysmal cold typically involves an autoantibody that's called P. You'll learn more about those in blood bank again, but I do ask that you know this chart. I think it will really help you on test questions. All right, other types of hemolytic anemias that are antibody-based are drug-induced. So again, if you stop taking the drug, it will stop the hemolytic process. So these are all due to different drugs that they might be taking. I am not going to really test you on these. These are just mentions. So we see here in the first example that ternary type, that's usually triggered by quinidine drug. And then the second one, hapten, is usually triggered by penicillin cephalosporin type drugs. So again, this is more informational. Some more on this side. So you see cephalosporins again, procainamide, methyl-dopa. That one a lot of blood bankers know about. So again, some of this is transfer over to blood bank still. So again, I'm not going to test you on these. They're just mentioned. And then finally, we have alloimmune hemolytic anemias. This is where your transfusion reactions come in and your hemolytic disease of the newborn, HDN. Both of these are heavily discussed in blood bank as well, but just a little bit on it. They're called alloimmune because you're getting it from somebody else. So in a transfusion reaction, you have gotten that antibody that's causing the issue from the blood product, that transfusion. Whereas in the hemolytic disease of the newborn, it's the mom producing an antibody against the baby's, antigens that it's not used to. It views the fetus's antigens as kind of foreign, and it might produce an antibody to attack it, resulting in a hemolytic disease of that newborn then. So that's kind of what it's going through. Again, you'll learn more later, but just on the hemolytic transfusion, you can kind of separate those into two subcategories. You have an immediate. The immediate would be, like it sounds, instantaneous. And this would be an example of if you were to give somebody the wrong type of blood. We've always said blood bank is life or death area of anything else. It really is. So, if you're one type and you get a whole nother type that's not compatible with you, that would result in an immediate reaction, very fatal to that patient possibly. And then delayed could be different antibodies that are in there that just take a while to hemolyze after the transfusion. And then down at the bottom, a classic example of HDN occurring would be, again, if the mom is Rh negative, but the baby's Rh positive. That's where that whole RhoGAM stuff comes in. I don't know if you've known anybody that has it or not, but it's a very common process now, and that RhoGAM takes care of it. But again, you'll learn that whole process later on, so I'm not going to go into depth on these. So we are good. I think if I were to look at this PowerPoint, there's not a lot I'm going to ask on it, very little, if anything. I would know that chart. That should be your best thing to know out of anything. Definitely look through it, read through it, but, do the lab review question, but for sure, know this chart before anything else. So that's it. If you guys have questions, please let me know. Otherwise, have a great week 10. Thank you.